Quality improvement and the model for improvement. Hunter Gatewood, Improvement Advisor. MFI is an organized approach to getting better results when you are working with other people. Reference for all model for improvement slides. The Improvement Guide, Langley, Nolan, Norman, and Provost, Jossie Bass, 1996. Most of the content of this presentation of quality improvement and the model for improvement comes from a day-long course, The ABCs of Quality Improvement, which was co-authored by the Institute for Healthcare Improvement and the California Healthcare Foundation in 2007. Slides on Understanding Variation in 30s of slide deck adapted from NHS Scotland Tutorial Guide on Statistical Process Control. Learning Session 1. SRIP RHP10 Learning Collaborative on Behavioral Health, Primary Care Integration. January 29, 2014. What is quality improvement? Before showing this slide, ask participants how they define quality improvement. Build off their comments. System level, not personal be better but system change that makes quality the default, decreases chance of error, dropped balls, etc. What is quality improvement? Change at system level. Work at the frontline level. By multidisciplinary staff teams. Regular, ongoing assessment and measurement. Reduction of variability. Process focus, not individual is good/bad. Examples: establish reminder system to reduce no-shows. Develop system to identify patients needing LDL test. How do we do things better? She is an organized approach to getting better results when working with other people, when it's more than just you. What is quality assurance? The planned and systematic activities put in place to ensure that quality requirements for a product or service will be fulfilled. Ensure that requirements, guidelines, regulations met. Uses inspection versus regular measurement. Also known as quality control. Examples: health code for restaurants. Licensing of providers. Audits of clinical facilities. Are we, you, doing things right? QA more regulatory in nature. The philosophy is grounded more in inspection and making sure services or products meet standards, as opposed to QA, which continuously tries to improve the status quo through regular measurement and change at the system level. QA may be static, versus QA, which is rooted by its nature and continuous change. Change is an improvement? Model for improvement. What are we trying to accomplish? How will we know that A measures change is an improvement? What changes can we make that changes will result in improvement? Act, plan, study, do, rapid test of changes. Today, we're going to talk about the philosophy and key concepts to quality improvement, starting with the model for improvement. The model for improvement was first developed by Tom Nolan and colleagues, and is described in detail in the Improvement Guide, Langley, Nolan, Norman, and Provost, Jossie Bass, 1996. The model for improvement is based on the idea that every system is designed to give the results that it gets. For different results, you have to change the system. The 3 questions in the plan, do, study, act cycle give you a method to learn how to make the changes that will result in improvement. From Associates in Process Improvement. Model for Improvement, Part 1. Aim Statements. Monthly Measures and Run Charts. But first, 3 more distinctions: Learning Collaboratives, SRIP projects, and the Model for Improvement. Model for Improvement is a powerful structure to use with any improvement goal. It's central to a learning collaborative, but you can use it outside of a learning collaborative. In a learning collaborative, all teams focus on the same improvement topic, care transitions. So aim statements and measures are focused on improvement and care transitions. SRIP projects cover a huge and impressive range of topics, many are related to care transitions, and many are not. Many SRIP projects' progress are crucial to powerful sharing with each other to drive better care and care transitions. And others you will want to keep separate from LC work, because it's not relevant and you don't want to do any more reporting and sharing work than is useful to you and to your RTN colleagues. Diagram credit, hhs.gov, from original at www.ehe.org, 3 different uses of numbers. Research. Judgment. Improvement. Research, hypothesis, measure, analyze, report, done. Judgment, audit, inspect, maintain standards, often for public good. Improvement, we fix our work ourselves, with our ideas and our approaches. Question, in SRIP measurement and numbers reporting, which use of data is that? Judgment, because it's overseen by state and federal regulators and there's money at stake. Money given or withheld, it's always about judgment. And you use improvement type measurement and activity to get the results to get the money. Other improvement models. Six Sigma. Lean, Toyota Production System. TQM. CQI. The rest of the slides on Six Sigma and Lean are optional based on the audience background and desire for participants to have overview of these models. Change is an improvement? Model for improvement. What are we trying to accomplish? How will we know that a change is an improvement? What changes can we make that will result in improvement? Act, plan, study, do. You're all familiar with the model for improvement now. We are now going to break down each of the 3 questions for the step-by-step processes to answer them. And, here it is again, the model for improvement. From Associates in Process Improvement. Characteristics of good aim. Focused, sets a clear goal to focus the team. Measurable, can develop clear measures to track progress toward aim. Defines success numerically. Time specific, establishes time frame, 6 to 12 months. Clinically relevant, compelling. Defines patient population. Adapted from the Institute for Healthcare Improvement Breakthrough Series College. Example aims. Within 12 months, decrease the percent of patients with greater than 3 ER visits a year. Within 6 months, reduce waiting time for primary care appointments in SCC clinic to third next available appointment delay of 3 days or less. By December 2012, decrease the percentage of diabetic patients with HbA1c greater than 9 to 10%. By, when, increase/decrease, what, for, whom. Assess the aim, example 1. The CHI team will meet 5 times in the next month. Focused, sets a clear goal to focus the team. Measurable and defines success numerically. Time specific. Clinically relevant. Defines patient population. Measurable meeting/5 times time specific next month May 2012 would be better, clinically relevant. PT Pop CHI team. Assess the aim, example 2. By December 2014, increase by 50% the percentage of patients with diabetes who got an HbA1c test in the past 12 months and have HbA1c less than 9%. Focused, sets a clear goal to focus the team. Measurable and defines success numerically. Time specific. Clinically relevant. Defines patient population. Wordy sounds good. Measure percentage of patients who have had a HbA1c test / increase by 50% time December 2008. Clinically relevant? 95% then number 10% then yes pop DM patients reword to actual percentage. Change is an improvement? Model for improvement. What are we trying to accomplish? How will we know that a measures change is an improvement? What changes can we make that will result in improvement? Act, plan, study, do. You're all familiar with the model for improvement now. Breaking down each of the three questions, working on number 2. You're all familiar with the model for improvement now. We are now going to break down each of the three questions for the step-by-step processes to answer them. Change is not always an improvement. We are going to give you the tools so that as you make changes you can figure out if they move you closer to your aim, no effect, or away from it. We will do this by looking at our measures. Measurement for improvement. Purpose, to track progress, improvement, over time and to promote buy-in. Audience, CHI team, frontline staff and providers, senior sponsors. Measure things that have meaning. Audience, anyone interested or affected by the process of achieving the aim. 16. RHP 10 Shared BHPC Integration Measures Pre-Work, Appendix D. Patients screened with cross-specialty tool. X. PHQ for depression in primary care, or diabetes screening on behavioral health. 2. Patients receiving integrated care intervention in past 12 months. X. Shared care plan at both BEH and PC sites. 3. Patients receiving integrated care whose condition improved, tracked cross-specialty. X. PHQ-S from +2, in primary care, or HbA1c down and tracked/reported in BH. 17. Characteristics of a good measure. Directly relates to aim. Specifies patient population. Data are available. Able to collect data frequently. Worth measuring for at least 12 months. Data are available. Important. Use what you have. As you develop a registry or EMR you may collect different data. Collect frequently. Saw this with PDSA cycles. What we are showing you today is a different tool to use for quality improvement. 18. Example measures. Number of days until third next available appointment. Aim, within 6 months, reduce waiting time for primary care appointment to 3 days. Percentage of patients with HbA1c greater than 9. Aim, by December 2012, decrease the percentage of diabetic patients with HbA1c greater than 9 to 10% or less. As part of measure development, also think about sources of the data that will need to be collected. Establishing measures goes hand in hand with starting to think about data sources, and how to collect and use the data. A little bit of a review. What are you actually measuring? Sample measures from audience. 19. Assess the measure. Example 1. Number of times the CHI team meets each month. Directly relates to aim. Specifies patient population. Data are available. Able to collect data frequently. Aim, the CHI team will meet 5 times in the next month. In reality, not a good measure because it is not clinically relevant. There is no patient population and the number of meetings held does not correlate to process improvement. The CHI team will meet 5x in the next month. The aim is the problem. 20. Assess the measure. Example 2. Number of improvements to the care of patients with diabetes. Directly relates to aim. Specifies patient population. Data are available. Able to collect data frequently. Aim, improve the care of diabetic patients over the next 12 months. Improve the care of diabetic patients over the next 12 months. Data available on what is an improvement? Need to define improvement. Quote Foot Care Study. 21. Assess the measure. Example 3. Percentage of patients with A1C testing during past 12 months. Directly relates to aim. Specifies patient population. Data are available. Able to collect data frequently. Aim, by December 2012, 90% of DMPTS will have had an A1C in the past 12 months. By December 2008, increased by 50% the percentage of patients with diabetes who have had an A1C test in the past 12 months. 22. Sample run chart. Median. Run charts display ordered sequence of data and provide running record over time. Can be used for any data that are sequenced over time, trending. Require no statistics. Visually illustrate progress toward goal. Adapted from NHS Scotland Tutorial Guide on Statistical Process Control. http://www.indicators.scot.nhs.uk/sbc/sbc.html. Understanding variation. All sets of data demonstrate variation. Two types of variation. Random/common cause. Normal, no change, not special. Special cause. Something going on. Examples of variation in a set of numbers: how long it takes to get to work each day, the volume of cereal in a box, the size of apples, the length of hairs in a buzz cut, the height of kids in a second grade class, the height of waves at the beach, the amount of coffee in a large Starbucks drink. Adapted from NHS Scotland Tutorial Guide on Statistical Process Control. http://www.indicators.scot.nhs.uk/sbc/sbc.html. Detecting special cause variation. 4 run chart rules. Astronomical point. Shift. Trend. Number of runs. Did the change result in improvement? 27, 1, 2, 3. Change made. HG note: what conclusions can we draw about significance of the change in these charts? First, need the median line drawn, then need to use run chart rules. 3. Change made. 28. Benefits of run charts: tells story, visually focuses on the process. Prevents jumping to unfounded conclusions about what doesn't work. Motivates people to think like improvers. Team meeting 1, aim statement and measures. Put slide of LC measures back up. Sample aim plus measures for BHPC integration. By December 31, 2014. Super Behavioral Health Clinic will improve the integration of behavioral health in primary care. For our patients seen at Advanced Primary Care Clinic, we will increase percent patients with diabetes with a diabetes self-MGT goal from 30% to 90%. Increase percent patients with a shared care plan at both SPHC and APHC from 0% to 80%. Decrease percent patients with diabetes with A1C over 9 from 20% to 10%. 31. Model for improvement, Part 2. Test changes small, using the Plan to Study Act cycle. What changes can we make that will result in improvement? Model for improvement, act, plan, study, do. What are we trying to accomplish? How will we know that a change is an improvement? What changes can we make that will result in improvement? Act, plan, study, do. Drilling down into your data will hopefully give clues for changes that actually do make an improvement. The MFI and PDSA cycle provide a common language for testing the effect of your changes. Emphasis here on methods that help you work on activities that will bring not just change, but change for the better. The AIM and initial change activities are selected based on past experience, best guess, borrowing best practices from others, etc. The measure is our tool to see if initial and ongoing activities cause a change from the status quo. Now comes the third step, using tools and methods that tell us if we are going in the right direction. Are things getting better, or are they staying the same, or actually getting worse? We need a process to do this analysis, and to incorporate the analysis into planning for the next set of improvement activities. From associated and process improvement. Learning objectives. Learn the value of testing changes and care on a small scale before implementing widely. Learn how to turn your ideas into tests, PDSAs. Plan a PDSA test to complete when you return to work. Why do small tests of change? Understand the likelihood that change will result in improvement. Understand the extent and limitations of the change. Learn to adapt the change to local environment. Evaluate cost. Address unexpected consequences. Gain buy-in and minimize resistance if change is implemented and spread. 1. Testing provides evidence that a change really does result in the improvement that was expected. Even though a change may sound like a good idea, you don't know until you actually use it in practice. 2. There can be multiple changes needed in order to produce the desired effect on your system. 3. Even though a change may have produced the desired effect in a different setting, you don't really know how it will work in your particular environment until you try it. 4. Change sometimes produces unintended consequences. Testing lets you to observe the costs, resources, time, equipment, etc., that the new process might involve, as well as the side effects that might come with the change. For example, providing same-day access for clinic patients may affect the process for locating medical records. 5. It is often easier for people to agree to try a new way of doing something if the change is presented as a short-term, small-scale trial. Let's just try this for 3 days. In this way, they don't have to immediately abandon the old way of doing something. Testing often shows people that the new way is really better, and they are then more willing to embrace the new process. Adapted from the Institute for Healthcare Improvement Breakthrough Series College. 35. PDSA-Rapid Cycle Improvement. Act. Questions and predictions, why? Plan to carry out the cycle. Plan. Study. Do. Carry out plan. Document. Begin data analysis. Complete analysis. Compare data to predictions. Summarize what was learned. Adapt. Adopt. Abandon. 4 parts of the cycle. Plan. Decide what change you will make, who will do it, and when it will be done. Formulate an hypothesis about what you think will happen when you try the change. What do you expect will happen? Identify data that you can collect, either quantitative or qualitative, that will allow you to evaluate the result of the test. Do. Carry out the change. Study. Make sure that you leave time for reflection about your test. Use the data and the experience of those carrying out the test to discuss what happened. Did you get the results you expected? If not, why not? Did anything unexpected happen during the test? Act. Given what you learned during the test, what will your next test be? Will you make refinements to the change? Abandon it? Keep the change and try it on a larger scale? Adapted from the Institute for Healthcare Improvement Breakthrough Series College. PDSA Step-by-Step. Identify a daily process need/problem. Brainstorm possible solutions. Choose one to test. Write a plan for your test. Do it. Conduct the test and document the data. Study the data to determine whether or not this test solved the problem. Take a seat in your most logical next step to solve the problem or retest for effectiveness. Example of PDSA subject: diabetes, Plan visits for blood sugar management. Plan, ask one patient if he or she would like more information on how to manage his or her blood sugar. Predict, patient will say yes. Do, Dr. J asked his first patient with diabetes on Tuesday. Study, patient was interested, Dr. J was pleased at the positive response. Act, Dr. J will continue with the next 5 patients and set up a planned visit for those who say yes. Source, ehe.org. Get one tennis ball for your group. Pick team's timekeeper. Exercise. Stand in groups of 8. Get one tennis ball for your group. Pick team's timekeeper. Name your team, quickly. Plan multiple cycles for a test of a change, and think a couple of cycles ahead. Scale down size of test, hash of patients, location. Test with volunteers, don't start with uninterested or resistant staff. Don't try for buy-in, consensus for every small test. Don't necessarily need consensus for tests. Run a set of tests. If people have more than one opinion, the team can learn more from a range of tests. Consensus only needed at implementation time, when we believe we have a lot of evidence for our theory of how the system works. Be innovative to make test feasible. Collect useful data, qualitative or quantitative, during each test. How will you use the results of test? If you aren't going to use results, don't waste your time doing the test. Test over a wide range of conditions, days of week, staffing variables, etc. 25. Hey, let's go see Homer blow himself up. DVD at Chapter 6 Rocket Roulette, from 34:37 to 41:00, 6.5 minutes. It is based on the true story of Homer Hickam, a coal miner's son who was inspired by the launch of Sputnik 1 to take up rocketry against his father's wishes, and eventually became a NASA scientist. Video, October Sky. Scene 6, Rocket Roulette, from 34:37 to 41:00. Repeated uses of PDSA cycle. Hunches, theories, ideas. Changes that result in improvement. A. P. S. D. Data. Very small scale test. Follow-up tests. Wide-scale tests of change. Implementation of change. Testing or adapting a change idea, start with one patient or provider, tweak it, then spread to 2 to 3 providers. Implementing a change. Spreading the changes to the rest of your system. Adapted from the Institute for Healthcare Improvement Breakthrough Series. College, Keys to Successful Small Tests of Change. Scale down, do small tests. Collect useful data during each test. Test over a wide range of conditions. Plan multiple cycles for a test of a change, and think a couple of cycles ahead. Scale down size of test, hash of patients, location. Test with volunteers, don't start with uninterested or resistant staff. Don't try for buy-in, consensus for every small test. Don't necessarily need consensus for tests. Run a set of tests. If people have more than one opinion, the team can learn more from a range of tests. Consensus only needed at implementation time, when we believe we have a lot of evidence for our theory of how the system works. Be innovative to make test feasible. Collect useful data, qualitative or quantitative, during each test. How will you use the results of test? If you aren't going to use results, don't waste your time doing the test. Test over a wide range of conditions, days of week, staffing variables, etc. Adapted from the Institute for Healthcare Improvement Breakthrough Series. College. 25. Run PDSAs in parallel. Specific test cycles. Implement registry. Group visits. Workflow redesign. Team care approach. This diagram illustrates how our hypothetical team that is trying to achieve improved access actually carries out tests in several different categories of changes. In order to improve timeliness of care for patients with diabetes, aim, improve % of diabetics getting HbA1c, lipid tests and foot/eye exams within recommended interval, the team probably cannot rely solely on implementing the registry. Changes in other areas such as developing group visits, workflow redesign, and instituting a team care approach should be considered. These multiple changes can be made simultaneously or can be folded in at plan intervals. We encourage teams to try packages of changes to achieve maximum results. At a later stage, specific changes can be removed to assess the impact of a particular change on the overall result. Adapted from the Institute for Healthcare Improvement Breakthrough Series College.